Good day, everyone. So I'll be taking the case presentation. I present Miss NSO, a 33-year-old lady. She's a student who resides in Calabar, Nigeria. Presenting complaints were progressive abdominal swelling of 3 months duration, generalized body weakness of 1 week duration. Abdominal swelling was noticed 3 months prior to presentation. It was generalized and had been recurrent for 4 years. There was no abdominal pain. She also had anorexia, early satiety, yellowness of the eye, and constipation. There was no history of nausea, vomiting, passage of pale bulky stool, pruritus, or hematochezia. No history of fever, confused speech, neck stiffness, or neck pain. However, there was history of reversal of sleep pattern. There was no history of consumption of alcohol or herbal concoction, no known family history of similar occurrence. She had a past surgical history of exploratory laparotomy done 5 years prior to presentation, where an incidental finding of hepatitis B infection was made. She was seen by the gastroenterologist and management instituted. However, she defaulted treatment and follow-up visits due to financial constraints. No other known chronic disease condition in this patient and no known food or drug allergy. On general physical examination, we met a chronically ill-looking young lady in no form of distress. She was not pale, icteric, cyanose, not dehydrated, with breast atrophy. There was wasting of thenar and hypothenar muscle, with 1 finger clubbing, with bilateral lower limb edema extending up to the middle 1/3 of the leg. She was lethargic, disoriented in time. There was no hysterexis. Pupils were 3 millimeters in size, equal reactive to light and accommodation. Tone power reflex were normal globally. Power could not be objectively assessed. Her abdomen was distended, moving respiration. There was no area of tenderness. Peritoneal stretch test was negative. Liver, spleen, and kidneys were not palatable with liver span of 8 centimeters. Ascites was demonstrable by shifting dullness. For the cardiovascular system, her pulse was 100 beats per minute, and her blood pressure was 90/50 millimeters mercury. Other examination findings were essentially normal. So we made a diagnosis of decompensated liver cirrhosis secondary to chronic viral hepatitis B infection, complicated by hepatic encephalopathy, West Haven grade 2, precipitated by constipation. So we requested for the following investigations as listed. And here are the results. Antibody to hepatitis C virus was non-reactive. Human immunodeficiency virus was non-reactive. Random plasma glucose done at the time of presentation was 8.8 millimoles per liter. And then for the scan, abdominal pelvic scan, her liver was shrunken in size, and then it demonstrated homogeneously increased parenchymal echogenicity with granular echo texture and serrated margins. Portal vein measured 13.11 millimeters. The spleen was normal in size, and there was no obvious nodule or cystic mass seen. The kidneys were normal in size with normal corticomedullary differentiation. So an impression based on the scan was chronic liver disease with cirrhotic changes and onset of decompensation. The full blood count she did for us revealed thrombocytopenia with platelets of 73. And then our ESR, that's erythrocyte sedimentation rate, was elevated 77 millimeters per hour. The serum electrolyte urea and creatinine also showed elevated creatinine, which was 131.98 micromoles per liter with estimated glomerular filtration rate of 48.7 mils per minute. A repeat, which was requested for 1 week into treatment, showed an improvement in the creatinine. At this point, it was now 128.76 micromole per liter with eGFR of 50.1 mil per minute. And then in both results, her sodium levels were normal alongside the potassium levels. Urinalysis done had no significant findings. All the parameters were negative with a pH of 6.5, specific gravity of 1.020. The liver function test showed the aspartate aminotransferase was just minimally elevated, in addition to the total bilirubin as well as the direct bilirubin. Albumin was reduced minimally, 3.28 grams, as opposed to 3.8 being the lower limit of normal. Alpha-fetoprotein was 17.3 nanogram per ml, and her PT prothrombin international normalized ratio was her PT prothrombin time was 25 seconds, while her INR was 2.3. Child-Pugh score was 11, which placed her at class C, and her APRI score was 1.448, FIB-4 score 5.58, which was significant for cirrhosis in this patient, and MELD score was 20 points, alongside the MELD sodium score done as well. So our treatment plan for this patient was to commence patient on intravenous 5% dextrose water, 500 ml 4 hourly, plus 5 ml of vitamin D complex in each 500 ml. She was commenced on intravenous Keptrazone 2 grams daily for 72 hours. Thereafter, TAPS cefoxitin 200 milligrams PD, and then intravenous metronidazole 500 milligrams 8 hourly. Thereafter, TAPS metronidazole 400 milligrams 8 hourly. And then she had antibiotics for 2 weeks. Suspension lactulose 10 mils TDS, aiming at 2 to 3 loose stools, was also given, and intravenous 20% sulfur albumin daily for 5 days, alongside TAPS zinc 100 milligrams daily for 1 week was also given to the patient. TAPS tenofovir lefenamide 25 milligrams daily for treatment of the viral hepatitis infection, and also dietary modification. She was cancelled on dietary modification, consumption of white and lean meat with plant protein, and low salt diet, less than 5.2 grams sodium per day. Patient relative, alongside the patient, we also cancelled on the prognosis of the disease condition, and then close monitoring of vital signs and urine output as well was instituted. Improvement in clinical state of the patient was noted within the first 1 week. However, she was noted to have an increased frequency of stooling, about 5 to 7 times on the 7th day of treatment. Lactulose was withheld. She was noticed to have confused speech 3 days after, because she was now noticed at that point on the 3rd day to go to toilet, open bowel to stool only once on that same day, and alongside with a confused speech. So suspension lactulose was reintroduced at 5 ml daily, and then TAPS rifaximin 500 milligrams was commenced.
Hello? Hello?
Hello? Sorry, TAPS rifaximin 550 milligrams BD was commenced in this patient. However, clinical state deteriorated with further worsening of confused speech, irrational behavior, and then progression to hepatic encephalopathy stage 3, and thereafter death was noticed in this index. This index patient actually passed on while in our facility. Now, for this patient, several factors contribute to default of patients from treatment once they are diagnosed with chronic viral hepatitis B. And then in our index patients, the problem was financial constraints because she didn't have the money that was needed for treatment. So what happened was, after diagnosis 5 years prior to presentation, she went back home and then was being managed at peripheral centers for the recurrent ascites that kept on occurring in her case, with diuretics, names unknown, and dosages fully unknown to her. So it was when she now had this episode of hepatic encephalopathy, the family members and her friends rallied round to do a crowdfunding to bring her in for us to see. So for us, the challenge here was the late presentation of this patient, which did not allow for proper monitoring from onset of diagnosis up till the time of her demise. So thank you very much for your attention.
Thank you, Dr. Asamito, for your excellent presentation of a very sobering case. And if you have we'll invite any questions about the case, factual questions. You don't need to, if you have a question about the details that were presented, you can post it in the chat or speak them. I do have one question. Did the ultrasound show any ascites or liver mass in this case?
Yes, the ultrasound showed ascites. However, there was no mass in the liver when it was done.
Okay. And we have a question there about the best route to give antibiotics. Thank you, Getachew. I think we'll leave these questions about treatment to our speaker, including, is there a role for zinc, and which I think was mentioned that was given to this patient, and which is better to give, how to give the metronidazole. Well, it's a sobering case, but it reflects real clinical realities. And a good introduction, I think, to our speaker. Can I ask you to stop sharing screen? Thank you, Dr. Itamayo. So our speaker today is Dr. Evaristas Chukwudike, who's a consultant gastroenterologist at the University of Calabar in southern Nigeria. And Evaristas is a longtime member of our ECHO clinic and supporter of it, and very active as a gastroenterologist internationally. He's done work in the US and observerships with the ACG. He is a member of, I believe, a couple of World Gastroenterology Organization committees, very active in the WGO, and has really contributed greatly to our clinic in the past. So, Evaristas, it's great to have you speak to us today about this topic of hepatic encephalopathy. And if you would unmute and go ahead and share your screen, we're interested to get an update from you.
Well, thank you, Dr. Mark, for having me. Good day, everyone. Good morning, good afternoon, good evening, good night, and depending on where you're joining from. Today, we are going to narrow it down on hepatic encephalopathy. So I'm just going to discuss it under this basic outline. So hepatic encephalopathy is a complex neuropsychiatric presentation of significant hepatic dysfunction. It is characterized by disturbances in consciousness, changes in personality and behavior, with associated fluctuating neurological signs, and distinctive electroencephalographic changes, which we are going to look at as we advance in this discussion. Brain dysfunction in hepatic encephalopathy is caused by hepatic insufficiency or where there is a severe portosystemic blood shunting. And there is a wide spectrum of potential reversible manifestation in hepatic encephalopathy, ranging from subclinical features, as in minimal hepatic encephalopathy, up to hepatic coma, which is the last stage of this disease, and is associated with high morbidity and mortality. As we prevented, minimal hepatic encephalopathy occurs in about 70% of patients with cirrhosis, while we see overt HE from the studies, overt HE in about 30 to 45% of patients with cirrhosis. For patients that have an opportunity to undergo TIPS, post-TIP encephalopathy occurs in 24 to 53% of patients that accept this procedure. And the risk of first onset of overt hepatic encephalopathy is seen in 5 to 25% of patients within 5 years of diagnosis of liver cirrhosis. So a good number of patients with liver cirrhosis get to present with hepatic encephalopathy. And 40% recurrence is been noted to occur within first year after initial overt HE has been diagnosed. So it means that once it is diagnosed, the clinician should look up closely on this patient for another HE or to make effort to prevent it. And survival probability is not very good, about 42% at 1 year, and a follow-up and then 23% at 3 years. You can imagine like index patient that was diagnosed and follow-up was not optimal, patient abandoned care. So let's look at the pathogens of hepatic encephalopathy. We have what we call ammonia theory. There are so many theories that have been propounded for hepatic encephalopathy. I'll start with ammonia theory. Ammonia is produced by the catabolism of amino acids. This is achieved by transamination or oxidative deamination. So ammonia is detoxified in the liver by conversion to urea. And two major factors contribute to hyperammonemia in cirrhosis. One is the decreased mass of functioning hepatocyte. You know, in cirrhosis, there is markedly decreased functioning hepatocytes. Hepatocytes, you know, they help in conversion of ammonia to urea when in the urea cycle. So there's also portosystemic shunting as a result of cirrhosis and shunting through the systemic circulation into the brain. So when this happens, ammonia crosses the blood-brain barrier and get absorbed and metabolized by the astrocytes. And the astrocytes use ammonia to synthesize glutamine from glutamate. So when this, most of the time, there will increase osmotic pressure in the astrocyte swelling, and ammonia disrupts the tight junctions of the endothelium and causes increased permeability of various toxins into the brain. One of them is the ammonia. So this is the graphic representation of what happens in patients with a hepatic encephalopathy. Normally the load of the ammonia is from the bacterial action that occurs in the gut enterocytes, and also the protein breakdown. So, but the liver does a lot in mopping up this toxin. But in the case of liver cirrhosis, this doesn't get to be optimal, and there's shunting of ammonia into the brain. And this gets to leading to the conversion of glutamate to glutamine by the use of glutamine synthetase. So another theory is the amino acid theory. Normally, there is a ratio in favor of a branch amino acid like leucine, isoleucine, valine. But in patients with hepatic encephalopathy, there is reversal in favor of aromatic amino acid like phenylalanine, aniline, tryptophan. So these aromatic amino acids are precursors of first neurotransmitters like octopamine and phenylethylamine. So this will decrease the true excitatory neurotransmitters in the brain and increase the glutaminergic transmission. Normally, what is favored in the brain is the glutaminergic transmission. But in this patient, when there is reversal due to increased aromatic amino acid, you now have increased glutaminergic transmission. And this advances a case of hepatic encephalopathy in cirrhotic patients. They also have the synergism theory, where there are combination of multiple factors that potentiate ammonia neurotoxicity. There are also GABA theory, which GABA we know is a inhibitory neurotransmitter. And GABA increases, there's increase in GABA in hepatic encephalopathy, and GABA-like activity is also increased. This will also potentiate GABA transfer in the blood-brain barrier and worsens glutaminergic neurotransmission that occurs in these patients. Benzodiazepine, as we know, the so-called benzodiazepine theory, studies have shown that there's increased diazepam and desmethyldiazepam in the brain in patients with hepatic encephalopathy as against the normal patients who do not have HE. And also, flumazenil has been shown to reverse HE in some patients. Flumazenil is a benzodiazepine receptor antagonist. However, there's a drawback in this theory because there are some patients that of flumazenil that are not with HE that are not reversed. There was also what we call neurosteroid theory. So neurosteroids that synthesize in the central nervous system and peripheral nervous system, it is seen to increase in patients with hepatic encephalopathy. And neurosteroids potentiate GABA receptors and as well GABAergic tone. All this will drive glutaminergic neurotransmission. Other theories that have been introduced is zinc theory. Zinc as a cofactor that were in conversion of glutamate, glutamine to glutamate. Zinc is decreased in this patient. There's also manganese theory, as seen in neuroimaging that have looked at the globus in this patient, and mercaptan theory. All these are other theories that have been introduced for HE. For president of hepatic encephalopathy, this is multifactorial. And from this diagram, you could see so many insults that exert insults on the brain. We have a high dietary protein. High dietary protein will ultimately lead to increased protein load, increased ammonia load, which is not broken down by the sick liver and gets shunted into the brain. The GI hemorrhage is also another precipitant because it will finally lead to increased urea meal and increased ammonia production. Constipation will reduce evacuation of gut microorganisms, which will increase breakdown of urea and increased generation of ammonia in the gut. And because the liver is not able to mop up this load, there is shunting into the brain. Infections like spontaneous bacterial peritonitis, urinary tract infection, pneumonia, acute viral hepatitis, and all that, they are also known precipitant. Fluid and electrolyte disturbances should also be looked at because these are also precipitant of hepatic encephalopathy. We can have overdiuresis, which will lead to dehydration, hypokalemia, hyponatremia, hyponatremia, azotemia, and alkalosis. It's very important to mention alkalosis because in presence of alkalosis in hepatic encephalopathy, ammonium is deionized to ammonia. So you now begin to have increased ammonia load in the gut, unlike in the patient who doesn't have alkalosis. So we also look out for alkalosis in management of patients with hepatic encephalopathy. Hypoglycemia, hyperglycemia. Drugs like CNS depressants are all known causes precedent of hepatic encephalopathy. We have hepatic insult like alcohol, herbal medications, surgery tips. But it's also interesting to note that about 20 to 30% of patients with hepatic encephalopathy, you may not be able to find the obvious precedents to this illness. So let's look at the clinical manifestation and staging of HE. The severity of neurological dysfunction in hepatic encephalopathy is variable. Usually depends on if patient presenting an acute encephalopathy or acute liver disease or chronic liver disease. Usually in acute liver disease, more of patient will have more of worsening confusion. But this patient, worsening confusion in this patient respond better than patient with chronic liver failure with confusion. The clinical presentation also depends on the stage of the encephalopathy. Okay, we look at the grade A, grade 1 is far better than when you have patient with grade 4. If managed early. So we have a clinical grading of hepatic encephalopathy. The most commonly used the West 7 grading of HE. We have grade 0, where we have a lack of clinically overt cognitive dysfunction that can be demonstrated with neuropsychological studies. It may account for about 60% of HE in patients with proto-systemic shunts. Asterix in this patient is absent in this group of patients. And we can demonstrate it by looking at what we call a block design test, which you can see from this diagram. You can also have what we call number connection test, which if you want to assess for minimal hepatic encephalopathy, this factor is not overt. So it's covert encephalopathy. So this is a way to unravel it. We also have construction apraxia, where you look at where the doctor demonstrates the 5-point star and ask patient to draw it. You can also look at the clock and see what patient has done. The grade 1 HE is there may be a trivial lack of awareness. Patient may present with shortened attention span, impaired addition or subtraction, hyposomnia, insomnia. There may be patient may be euphoric or depressed. There may be mild confusion. Asceticism may be present or absent in this set of patients. In grade 2, you may have lethargy. So the patient may have lost speech. Asceticism is present most in this patient. There may be patient may be drowsy and the confusion is increasing. Patient may have inappropriate behavior and intermittent disorientation. Then in grade 3, the patient may be somnolent but arousable. And there is now marked on, a patient is now unable to perform mental tasks, unlike the grade 2, where patient there is a slowness in performing this task. And there's marked confusion and amnesia. And the last one is hepatic coma. There's also grading based on the etiology. So we have type A, type B, and type C. From the pool you just answered. Type A is, just as the name is, associated with acute liver disease. Type 2 is when there is proto-systemic bypass. That type B, the B is there, the bypass. And type C, when you have a patient who have a cirrhosis, portal hypertension, and all that. So they could come in as episodic, persistent, and minimal HE. So this is the diagram of the way it occurs in episodic. You could say the encephalopathy that is clinical. The patient comes down to normal, so patient may be normal for days to months, and then another encephalopathy occurs. They are also persistent encephalopathy and then clinically dependent. So, but whatever is the case, from grade 1 to grade 4, there is increased cognitive dysfunction and reduced level of consciousness that continues to progress as you go down this stage. Let's look at diagnosis of HE. Hepatic encephalopathy is a diagnosis of exclusion, meaning that there is no clinical features, symptoms, or investigation that is pathognomonic for this diagnosis. So it is mainly clinical and after exclusion of other causes of encephalopathy. So the diagnosis of hepatic encephalopathy should be considered when 4 major factors are present. One, there will be if there is acute or chronic hepatocellular disease and or extensive portal systemic collateral shunts. If there are disturbances of awareness and mentation. You also look at fluctuating neurological signs in patients who are managing, and also characteristic electrical and configuration features For instance, you could now have the alpha worsening of the normal alpha waves, theta wave, or even the delta wave in advanced phase. All these are features that will show you on EEG as to point out that there could be hepatic encephalopathy in the patient. Differential diagnosis, since it's a diagnosis of exclusion, we have so many exclusions we might have to make before we come up with hepatic encephalopathy. You can have intracranial lesions like infarct, tumor abscess, even cranial hemorrhage, infection, meningitis, encephalitis, sepsis. You also try to look at metabolic disorders, hypokalemia, uremia, alkalosis, and even when it gets encephalopathy, and sometimes in very rare symptoms like McAfee-Benami syndrome. All these we can mimic encephalopathy, so you need to exclude all that, and primary neuropsychiatric disorders. There are many investigations one can do, but none of them is pathognomonic. So we look at investigation to establish a diagnosis of liver disease and the severity of liver disease, and also help you to manage the patients. These are investigations we'll be looking at for. So the principle of management of hepatic encephalopathy, we'll be looking at, one is elimination of precipitating factors. Two is to decrease production and absorption of toxins. We need to increase liver function and clearance of toxins. We also have to make effort at preventing penetration of potential toxin into the brain. We also have to correct abnormal neuronal activities and supportive therapy. The best that could be done in the environment where it is available is liver transplantation, especially in type C hepatic encephalopathy. So the treatment, every patient with hepatic encephalopathy should be admitted in the hospital. There's no guideline like managing at home and patient present coming to the hospital. And patient will have to maintain effective resuscitation of this patient, make sure that airway is better, make sure that the patient is breathing well, make sure that circulation is intact. So for elimination of precipitating factors, we have to prevent GI hemorrhage and prompt treatment of GI hemorrhage where it occurs. Correction of fluid and electrolyte imbalance. We also have to make effort to treat infections. We have talked about that infections are precipitants. We also try to avoid hepatotoxic substances, be it drugs, herbs, or alcohol. Anybody managing hepatic encephalopathy should make effort to decrease production and absorption of toxins. There is this, do we supplement protein or restrict it? So protein restriction is now old practice in globally. It is now highly discouraged because these patients have marked anorexia, malnutrition, malabsorption, so we don't restrict protein in them. There is poor nutritional reserve. So we try as much as possible to give them normal calorie as other people. So maybe get a reasonably higher calorie. But is there any point where we should restrict protein? Yes. In acute liver failure, protein restriction is at the studies of the protein should be encouraged, and other cases of inborn errors of metabolism. Because in these cases, you have increased arginase activity. So what happens that if you load patient with much protein, you increase ammonia production, and this could precipitate hyperammonemia in such patients. So we take note of this. So there is decreased production. We also make effort to decrease production and absorption of toxin. Where our lactulose comes in is a non-absorbable disaccharide. It has wide antibacterial activity against both aerobic and anaerobic gram-negative and gram-positive bacteria. Those usually are 30 to 120 ml per day, or I bet we'll try to be at the safe range of 30 to 60 ml. Our aim is to maintain 2 to 3 loose stools per day. And it has other mode of action like acidification of intestinal content, making the gut environment acidic. It also catalytic agents and osmotic laxative. So it helps to evacuate the bowel, the bowel. So reducing the microorganism in the bowel that could increase ammonia load. It also donates proton, like hydrogen. Donation of hydrogen will increase production of ammonium, which is weakly absorbed, and reduce the production of ammonia. Very important in reducing the presence of hepatic encephalopathy. So it also make effort to decrease production and absorption of toxins. The neomycin was really initially used, but it has run out of favor in most centers. Right now, rifaximin is a very good choice. It's a synthetic non-absorbable antibiotics and has a very superior safety profile. The drawback of rifaximin right now is they're not available in many parts of Africa, even some other countries. But it's becoming available right now in some part of Africa, like in Nigeria. We now have rifaximin to manage a patient like index patient. We also try to moderate the interorgan ammonia metabolism. Arginine, it helps in driving the production to urea, thereby consuming ammonia. Sodium benzoate is also very important because increasing renal, by that part to increase renal excretion. Phenylbutyrate is also very important where it is available because also renally excreted. LOLA is L-ornithine L-aspartate. This medication targets multiple organs, both gut enterocyte and brain astrocyte. The safe dosage here is 20 to 40 grams per day in infusion. So what does it do? It increases glutamate production, decreases ammonia production. It also decreases cerebral edema and improves mental function. But LOLA is not recommended in acute liver failure because of the increased arginase activity and the reduction in arginine level in order not to precipitate hyperammonemia in such patients. This graphically describe what I have just presented. So we also make effort to increase function and clearance of toxins. The zinc supplement is zinc is a cofactor in the urea cycle, and it's been shown to increase glutamatergic transmission as against glutaminergic transfusion that is prevalent in a patient with hepatic encephalopathy. So it decreases the ammonia production by stimulating ureagenesis. So it's good to look at it, but we still need more studies in our environment in Africa on this to see if it works for us, as have been shown in some other literatures. We also try to correct abnormal neuronal activities. Flumazenil has been found to improve mental state in patients with HE, but is given intravenously. So that's a drawback, and it's not in all patients, but in patients with evidence of benzodiazepine as a precipitant. Hence, not available. It's also not available everywhere. Bromocriptine for correction of extraepidemic manifestation is also being advocated, but some studies are still not apart with this. Some studies have not established true benefit from bromocriptine. So we make effort for good glycemic control, as I've talked about, because it helps to reduce oxidative stress. It limits mitochondrial liver enzyme. In fact, it's an anti-shock to the liver, especially a patient with hepatic encephalopathy. It also improves endothelial activation, improves blood flow, limits tissue injury, and improves outcome. So probiotics, do we use or not use? Well, in HE, it's been shown that there's a decline in bifidobacterium and lactobacillus. Probiotics is fermented by colonic bacteria to acetic acid, butyric acid, to carry out its effects. And the effect of HE include reduction in intestinal ammonia production by enterocyte glutamate. So it also reduces bacteria translocation and moderate pro-inflammatory responses. It also moderates gut permeability. So probiotic may be useful in patients with HE, but there are still some controversial studies that one will find online. Seizure is a big problem in HE patients. So the overall incidence is very wide, from 2% to 33%. But what do? We have to make effort to treat the basic disease. We have to correct the precipitants. We have to image the brain. I also have to do electroencephalogram. We have to avoid sedative as much as possible in this patient. If where all these are done and patient we couldn't arrest the seizures, phenytoin and gabapentin are the preferred drugs. The studies is also outlined there. So patient may benefit from temporal hepatic support, extracorporeal liver acid device, molecular advanced circulatory system in environment where it's available. But I don't know many African countries where this is done. And definitive management will be partial hepatectomy, liver transplantation. With liver transplantation, it's been shown that there is a reduction in mortality that occurs in HE. And survival has increased in these patients, unlike the dismal survival rate we have when this is not available. So the complications include cerebral edema, brain herniation, there may be cardiovascular collapse, there may be kidney failure, respiratory failure, sepsis, and permanent nervous system damage can occur, and irreversible coma can also occur in this patient. So what we do to prevent this disease that is mortality is very high in our environment? If the studies in advanced world show this dismal outcome, then we could understand what happens in Africa with very low income patient pay out of pocket to access care. So we make effort to educate people on the risk factors for liver disease. We also try to do aggressive hepatitis B vaccination because in an environment like Sub-Saharan Africa, hepatitis B is the most common cause of chronic liver disease. We also try to prevent and treat and do any treatment of common etiology of chronic liver disease. And I also try to avoid prevalence of HE as much as possible in our patients. We also train and retrain health workers on how to diagnose the current guidelines in the management of diagnose the disease and the current guidelines in the management of HE. The index patient we just presented, she didn't return home. She went to one healthcare center, but they are not abreast on how to manage this illness. And so a patient now presented with hepatic encephalopathy as the outcome. So prognosis, acute hepatic encephalopathy may be treatable, and chronic forms of the disorder may be episodic or persistent. Both forms may result in irreversible coma and death. So high index of suspicion why these patients are being managed. And overall mortality may approximate 80% in all. So it is in an advanced world, mortality that being showed about 30 to 45%. But in our environment, mortality in hepatic encephalopathy is as high as 80%. And effort should be made to reduce this as much as possible. So our prognosis depends on the underlying etiology, grade of hepatic encephalopathy, the age of the patient. Younger patient, they do better than advanced patients in age. Time between the onset of hepatic encephalopathy and hepatic failure and encephalopathy in acute liver disease portends worse prognosis as time advances, increasing protein time, and failure to have liver transplantation. All these portend worse prognosis. This is where I will stop and wait for us for discussion. Thank you.
Wow, thank you, Evaristos. That was a fantastic review, very concise, but very thorough review of this subject. And I, for one, learned a lot from what you had to say. So thank you so much for your presentation. Now, please post your questions in the chat, and we'll ask Evaristos to comment. And we have some true liver experts on the call also, and I invite those of you who are in that category, please contribute your thoughts and perspectives from where you live and where you work. So Evaristos, question number one, role of zinc in hepatic encephalopathy. I think you already commented on that. Should it basically be given to every patient with this diagnosis?
All right, so the role of zinc in hepatic encephalopathy, ideally, zinc level in advanced should be looked for. What is the zinc level? But in some places in Africa, the lab cannot perform zinc assay. So one may look at it. So if I cannot perform zinc assay in this patient, and I don't know what is zinc level, and I know zinc is a cofactor, that's the basis in a low-income country where most people try to use zinc in the treatment of patients, but not for a blanket treatment.
Now, next question. Please clarify that if there is any benefit of tenofovir for HBV when the child's PUT score is already C, and maybe we'd extend that and say, is the presentation with hepatic encephalopathy in this patient an indication to begin tenofovir therapy?
Oh, okay. So this patient, the plain tenofovir should not be used in this advanced disease. But if for the index patient, she had hepatic encephalopathy, and there are also obvious renal impairment in the patient. So if you must use tenofovir, it must be tenofovir lefenamide, not plain tenofovir, because tenofovir may even worsen the nephrotoxicity. But tenofovir lefenamide has been shown to be renal friendly. So one should look at it.
And would you advise giving TAF to patients like the ones presented today?
if at the time the patient it wasn't. If the one that you present today, the EGFR was about 45 to 50. So if the EGFR is above 45 to 50, 60, one should not, one may use, and patient is not in encephalopathy, one can use tenofovir. But if there is encephalopathy, one should not rush to institute tenofovir. First, the most important thing is to get the patient out of encephalopathy first.
So you would, if the renal function is good, you would still wait to start tenofovir?
Yes, I'll wait to start tenofovir. I want to get the patient out of encephalopathy first, and then because there's no rush.
Okay.
Yeah, the US, because of, I think, well, if you look at Gilead's recommendations for tenofovir alafenamide, they say that it's not recommended for decompensated cirrhosis because the safety efficacy has yet to be established. I think the studies are ongoing, but you can renally dose TDF because that has been studied in the setting of decompensated cirrhosis, acute liver failure, and the safety efficacy has been established. But I think TAF looks promising, but we need the data to support that. So.
Thank you. And then a question, I think the question for you, Dr. Itamayo, was the possible precipitant for hepatic encephalopathy ever identified in this patient? What do you think?
For this patient, she had constipation. All right. And then when she presented to us, she had been at the peripheral center where they were giving her diuretics intermittently for the recurrent ascites. So those were the two likely things that would have precipitated her HA.
Thank you. And in fact, you addressed both of those in her treatment. Then there's some questions about calculating the APRI score. And I'll just say that there are online calculators available and ones you can put on your phone, apps. Here's a question for you, Evaristus. Did you consider to do CT of the brain for this patient since she was not improving? And could you comment more generally? When should you start to image the central nervous system? Maybe do a lumbar puncture in someone presenting with what seems to be hepatic encephalopathy.
Yeah, so that's the drawback of management in our facility. We consider the neuroimaging for the patient, but the challenge is when the patient to even procure the right drugs to even start treatment was a big problem. So neuroimaging should be done for patient with because that's one way to exclude all other differential diabetes, a diagnosis of exclusion. And neuroimaging should be, especially when you institute the initial management and patient is not, neuroimaging should be done as quickly as possible. But unfortunately, we didn't get to do that for this patient.
All right, but your general recommendation would be to do that in all patients or only those who are not improving? I mean, what's your view?
So I did for all patients with hepatic encephalopathy should have neuroimaging done.
Okay.
All patients with should have neuroimaging done. But in our environment where we are, where we practice, it is not feasible due to for some patients due to lack of funds to even do all that. So you need to look at the patient to manage, even with the guidelines.
And in addition to imaging, would you recommend lumbar puncture or only in special populations such as HIV patients? What's your view on that?
I think that for lumbar puncture should be tailored to patients that have the need. For instance, if you are thinking that you need to exclude meningitis in this patient, lumbar puncture should be done. And you think that there are other reasons why, like HIV patients, you are thinking about HIV encephalopathy and all that, you should look at those patients. But I don't think, I've not seen any guideline like that, but I don't think that it should be a blanket statement for everybody.
Thank you. Now, there's a question about lactulose usage. Does lactulose dosage efficacy have to do with the number of stools, or are you aiming for a certain number of stools every day, or is any passage of stool okay?
So lactulose should be aimed at the dosage of stools, because that's the way to determine if you are overdosing, underdosing. This patient should get lactulose. But one should also look at it, can worsen the encephalopathy because
Did we lose you, Evaristus? I'm not hearing you.
You can overdose and patient will begin to have a recurrent. However, if lactose is being admitted, you can now have an add-on, which is
Am I the only one having trouble hearing?
I can hear you.
Okay, sorry. I don't know if it's my internet or yours.
No, it's going in. Yeah, it's going in and out.
Okay, can you just repeat about dosing lactulose? Most of us didn't hear.
Okay, can you hear me now?
Yeah.
Okay, so I said that lactulose, we should look at the stool, the frequency of stool the patient makes. For us, we look at it so that we don't overdose our patient, because increased stooling is also a precipitant for hepatic encephalopathy, diarrhea. So we need to look at constipation is a precipitant. So we look at make sure that we are not overdosing, underdosing. So the stools should be also looked at. Stool chart should also be, the eye should be on stool chart when patient is on lactulose. So if patient is not improving and patient is getting optimal dose of lactulose, making adequate stool frequency, that's the time the guideline, ACG guideline says you need to add rifaximin. It can be an add-on, or start adding rifaximin itself.
Bring my coat when you come.
I don't know if you heard me.
Yes, thank you. That was good. And then there's a follow-up question. Do you give lactulose prophylaxis after discharge? If the patient's recovered, you're discharging them, should they receive this chronically?
Yes. We give lactulose as we discharge the patient. But we instruct the patient, we do a lot of education to make sure the patient understands that the dosing will depend on the stool frequency, so the patient will not get home and overdose himself or herself and then get into encephalopathy. So we do a lot of teaching before patient leaves our care.
And then there's follow-up questions again about lactulose. Do you use it in type A encephalopathy? Do you use it in acute liver failure?
So basically in patient with constipation, I've seen any study that contradicts use of lactulose. I've not seen I've not seen it contradict use of lactulose in acute. If there's constipation, lactulose can be used. I've not seen any study, but it is LOLA, L-aspartate, that is contraindicated in acute liver failure because of the increased arginase activity in those patients.
So you would use lactulose basically in any patient with hepatic encephalopathy?
Yes, I will use it. I will use it.
Okay.
If it's indicated.
Yeah, assuming they don't already have loose stools or frequent stools. Now, there's an interesting question here asking, what do you use for hepatic encephalopathy patients who are highly restless with marked agitation? So I guess my first question would be, is that consistent with the diagnosis of hepatic encephalopathy to be restless and agitated? And then if so, what do you use?
So if patient has has restless and agitated, confused and agitated, or restless. Restlessness is also can occur in hepatic encephalopathy, but we need to establish that it is hepatic encephalopathy. That's where we talk about, we need to make sure that the neuroimaging is done for this patient to exclude other causes of encephalopathy. So if there is, we need to also manage the patient just as I've outlined.
Thank you. And there's a question, how can we treat patients who's having diarrhea and at the same time having hepatic encephalopathy, especially when rifamycin is not available in our setting?
What's not available? Sorry, I didn't hear.
Oh, especially when rifamycin is not available, rifaximin.
Okay, rifaximin. So rifaximin, I said it in many parts of Africa. It hasn't been available up to now, but we need to make effort because the drug is becoming available mostly. But if it's not available, you need to withhold lactose if patient is making more than 3 to 4 loose stool per day. You don't need to institute lactulose. And again, you also look at people that have diabetics. Diabetes, where lactitol is available, that should actually be the right drug. So diabetics, because of increased sugar in lactulose, lactitol should be the ideal drug for diabetic patients. So these are things you need to consider as you are instituting the lactulose. So, but the rifaximin will be a very good one.
But when rifaximin is not available and the patient comes with diarrhea, what are our options in treating? That's the question.
Okay, so at that point, when you have patient with diarrhea, and now you need to find out what is the etiology of diarrhea, because some of the diarrhea could be because of the bacterial load. So you need to antibiotic can reverse the diarrhea depending on what is causing the diarrhea. So apart from lactulose, if it's not available, you also look to address the cause of diarrhea. Even when you're using lactulose, you also need to address that cause.
Now I'd like your comment some more on antibiotic use. Should cultures be done in patients presenting if they're available and affordable? And then should all patients receive antibiotics, all patients with encephalopathy, even if the cultures are negative?
So if patients have hepatic encephalopathy, and if you culture if you culture and you don't find any organism, if there's no organism, that would be I don't know what will be treating, but if you culture and there's no organism, still make efforts to make sure that you empty the gut, because the bacteria in the gut can cause a lot of problems. They can also increase ammonia load. So we need to make sure that you protect the patients so that the patient don't develop increased ammonia and worsening of the encephalopathy.
There's a question about secondary prophylaxis. So this is someone who has had hepatic encephalopathy, been hospitalized, improved, and is now going home. Should that patient receive chronic lactulose alone or lactulose plus rifamycin if it's available?
If in the course of management, patient does well with lactulose, that will remain the first line. But if patient is managed, while you are managing the patient is on lactulose and didn't do well while you are instituting lactulose, that is the add-on is rifaximin. So you need to look at the patient when you are managing the patient and what you are going to discharge patient on.
Okay, thank you. There's a question here about lactulose use in the presence of hepatorenal syndrome. Is that a contraindication?
Yeah, if you have for a patient with hepatorenal syndrome, there's a study that it's been said that one should be careful with use of lactose. So I think if you have hepatorenal syndrome, your effort should be to reverse the hepatorenal syndrome as quickly as possible.
And then the question is, when do you see asterixis in grade 1 encephalopathy? And if the patient has asterixis but is still oriented, is that what grade 1 is? I think the question is getting at diagnosing the disease early, maybe diagnosing it in the clinic. Can you clarify how you diagnose grade 1?
So there's clear guideline on grade 1. So even there are some studies that have talked about. Even the grading of hepatic encephalopathy, looking at that grade 0 and grade 1 are actually minimal hepatic encephalopathy. So that grading, and I said that's grade 2 to grade 4 is now the overt HE. So you need to look at this patient. If patient is lethargic, patient has marked confusion, and so you need to look at because it's not only asterixis that you use to diagnose grade 1. You need to look at all those parameters I had outlined. Does patient fit into all that? So the asterixis will be considered whether it's grade 1 or grade 2, depending on all other parameters you are also seeing.
Thank you. All right, there's other questions also, Evaristas, but we're over time already. And so I want to just give Tinsei a chance to comment. And if you have anything to add, we'd love to hear your thoughts coming from Baltimore in your liver clinic. I mean, do you use the number connection test in your clinic routinely to screen for this? Do you have any other practices we should learn from?
Oh, okay. Thank you so much. Yeah, thank you for that wonderful presentation. It was very thorough, it covered basically everything. So, in our practice for the minimal overt encephalopathy, we don't routinely do it in the general hepatology clinics. We do have that available in our transplant. So some of the specialized clinics, we do have that available. But I think because of time, we don't routinely do it. But that may be something we need to work to implement, because we can miss a lot of patients with that diagnosis in the general hepatology clinics. And so I actually see, acute liver failure being a tertiary care center. So we do get, usually a handful of cases per year. And the data for the use of lactulose in that setting is not as clear as for chronic liver disease. And our transplant surgeons often ask us to discontinue it because it can lead to bowel distension that can make the liver transplant operation. So if any of you are at transplant centers where patients with acute liver failure present, just something to consider. And that's also in the guidelines as well. And so, but it is one of the most frequent admissions we have to our inpatient service. Hepatic encephalopathy causes a lot of morbidity, the cost of hospital admissions. And so I think it's important to have newer treatments. So it was nice to see all the data presented. Thank you.
Do you give rifaximin to every patient you admit with this diagnosis?
Yes, given the data that it has been shown to decrease risk of rehospitalization. We also actually run into the issue of cost a lot in the US. So I think it's very expensive, even oftentimes insurance does not provide full coverage, so that patients have significant copays that can exceed $1,000 a month, and our patients can't afford. So I had a patient yesterday I saw, and they actually asked me to submit the script to a Canadian pharmacy where they said it was just $100 versus $1,000. So the cost is a big limitation. Sometimes we can appeal if they have recurrent admissions and get it approved, but unfortunately it is an expensive medication, although effective.
Thank you for commenting, Tinsei. And so Haile Mikhail, I don't know if you're on the line and if you want to make any comments.
Prof, thanks so much. I would like to say Happy New Year for those training today, and sparing at least 1 hour for this eco session for all participants. And Prof. Mark for moderating this session, Evaristas, Asa Ito, Asa Itam for the excellent session. I think I would like to say, like, hepatic encephalopathy is probably there are evolving changes in the management. Some probably updated in the management that I have seen is in the microbiota. I don't know whether since I had to use that. There are some studies on the microbiota and alteration in the microbiota as a cause or a precipitant for hepatic encephalopathy. But usually for us, cirrhosis is the main cause. It's difficult to measure ammonia level. It's difficult to get the rifaximin. Ammonia level measurement may not be always important, but we'll try to find lactulose as a first line. And as has been said, if they have lactulose and rifaximin combination, that was better to prevent recurrent encephalopathy. Hepatitis B has been the major cause for our patients, and early transplant evaluation is also important for these patients. Thank you, Prof. Thank you all. Back to you.
Thank you. So the final word I'll give is that we're really interested in hearing from you about what's the most interesting case you've seen recently. We'd love to have you present it here at this clinic. So please, I'll put my email in the chat.
Yeah.
Please email me telling me about the interesting cases you've seen that you might potentially be interested in presenting here, because we could all learn from your experience. Even if you don't have all the answers, that's not a problem. You're working in setting like similar to many of us. So please email me with case suggestions. We'd love to hear from you. And we'll plan on seeing you in 2 weeks. Thank you again, Evaristas and Dr. Itamayo. And Happy New Year again to those of you who are celebrating today.
Yeah. Thanks so much.
Happy
See
New
you
Year
in
too.
2 weeks.
Happy New Year too.
Thank you.
Okay.
Yeah.
Thank you very much.
Yes.
Happy New Year.
Yeah. Thank you.
Okay, thanks.
Yeah.